Thank you very much for attending this talk. What I'm going to talk about today is how machine learning can drive the transformation of healthcare delivery. And I often like to start my talks with this quote from Sir William Osler, the father of modern medicine. If it were not for the great variability between individuals, medicine might as well be a science, not an art. And indeed, as you know better than me, medicine is hard. And this is due to the variabilities between individuals, which lead to different risks, variation in symptoms, health and disease trajectories, and responses to treatment. So the art of medicine has been over the centuries to make judgments on the basis of this complex information to manage patients. And what I personally believe that machine learning can do is enable clinicians to turn this art into a science. What specifically do I have in mind? Machine learning can transform healthcare by delivering precision medicine at the patient level, understanding the basis and trajectories of health and disease, empowering healthcare professionals, but also patients, informing and improving clinical pathways, better utilization of resources while keeping the cost low, transform population health and public health policies, and enabling new discoveries, both clinical as well as new therapeutics. Let me say upfront that I do not believe that machine learning can do medicine. What it can do is can provide interpretable and trustworthy, actionable information to support clinicians in their decision-making process, whether it is through personalized risk scores, personalized treatment recommendations, as well as data-driven hypotheses. And here you are going to hear today not only about personalization to the patient, but also personalization to the unique skills and unique needs of the clinician. So the personalization will have two aspects, one to the patient and one to the specific needs of the clinician. And indeed, I would like to advertise here an engagement session that we started 1.5 years ago. We call it Revolutionizing Healthcare. And we have right now 500 plus clinicians from around the globe participating in these sessions. So if you want to learn more about machine learning and what it can do in medicine and converse with us, the machine learning community, and develop ideas and tools, please go to my website, Van Der Schaar Lab, and look under engagement sessions to the Revolutionizing Healthcare section. And if you are a clinician, you can subscribe to these sessions. If you are not a clinician, but you are interested in this, you can see the various sessions on our YouTube channel. And we indeed talked about a variety of topics, from better cancer diagnosis to organ transplantation, from hospital care to machine learning interpretability. We also have a sister series. It's called Inspiration Exchange, and there the focus is quite the opposite, is to excite machine learning researchers, especially young machine learning researchers, to learn more about the interesting yet complex problems that medicine is posing. Today, I'm going to have a very begin overview of how I think that the healthcare ecosystem can be powered by ML. And then I'm going to take one particular example, one of the many examples, to discuss how machine learning can bring early diagnosis and detection in the next era. So first, as an introduction, how can machine learning really transform healthcare delivery? By getting the right care to the right patients and achieving the best outcomes at the lowest cost. And this is possible through personalization, learning at scale, so learning not only from one particular location or one particular clinic, but at the level of a country or even across countries. And often there has been a lot of discussion during this pandemic that there was a lost opportunity to learn more at scale, to learn more across institutions and from each other. And machine learning can serve as a vehicle to enable such learning at scale, identifying better ways of working and inefficiencies, providing concrete policies for improvement, and also maybe more mundane, but even more important, allocate resources that are needed, whether it's hospital beds or the specialized time of clinicians over time in a more optimal way. So we have divided the opportunities of machine learning in healthcare in 4 different areas. And what you see here is that we have divided it in ideas that are aimed at supporting the patient or the profession, in this case, the clinical profession, narrow and broad. So one of them is bespoke medicine, which goes beyond personalized medicine. If you want to learn more about how we can go beyond just precision and personalized medicine, please take a look at the Revolutionizing Healthcare session where we discuss this. Building tools to empower clinicians, enabling system pathways and processes to operate more effectively on the basis of the available data, but also insights we can derive from this data. And finally, as this pandemic has shown, enabling better population health and public health policies, as well as clinical practice guidelines. Why is now the right time? There are multiple reasons for that. First, machine learning methods have come of age and are increasingly ready to use, as you are going to see in a little bit later part of this talk. Also, in order to be able to learn, we need to have access to high quality, valuable data. And this is increasingly becoming available in the form of clinical notes, electronic health records, clinical registries, prescription information, but also appointment information or wearables. These are just some of the many sources of valuable information. And what information is valuable for what type of decision, for what type, for instance, of risk, or what type of trajectory, or what type of treatment needs to be learned. But these different sources of information can be integrated together to provide actionable intelligence to clinicians. And the COVID-19 pandemic has accelerated this digital information collection. So one important thing we are trying to achieve is a personalized and comprehensive care ecosystem with machine learning. Currently, there has been written a lot. For instance, Atul Gawande wrote very eloquently a series of articles discussing how poor the current electronic health records are, whether it's the EPIC system or many others. And they are often just a data entry exercise that takes valuable time from clinicians without offering much in return. But if machine learning is to be used on that, and a good high quality interface that's co-designed together with clinicians is to be put on top of these electronic health records, we can go to the next level in empowering clinicians and patients. And what you see here is some examples of a series of machine learning enabled platforms that we have built together with clinicians, whether it's for the treatment of cancer patients, with breast cancer, whether it's for hospital care, or whether it's in organ transplantation. You can see some of this in this Revolutionizing Healthcare session. And they are built on a variety of machine learning technologies that are highlighted there: adjutorium, autoprognosis, clairvoyance. I'm going to briefly talk about a few of them later. So what really I have in mind when I say that the entire healthcare ecosystem can be empowered by machine learning, on the basis of the available healthcare data, data-driven machine learning can provide tools for empowering clinicians. It can provide personalized recommendations to patients. It can provide hypotheses that can empower clinical research and development, but also analytical tools that enable hospitals or clinics to operate better. And one example there is hospital administrators, but it could be much more than that. Provide insights for healthcare bodies. Right now, many clinical practice guidelines are of a one-size-fits-all, plus many diseases may not even have very accurate and good guidelines. So there is an enormous opportunity to learn and extract insights, personalized insights, and provide better guidelines. And finally, really provide recommendations for public health policies. Most of the work that we have in mind is targeting clinicians. So it's developing machine learning methods that are invented and co-invented together with clinicians, because we do not want to invent something that is useless and cannot be used in practice, but rather try to discuss with clinicians, understand their needs, and build together with them tools that hopefully are going to make a difference. I'm going to give you just one example, but you can see many more on our website. You can look at the impact section and you are going to see there examples from cancer to cystic fibrosis to Alzheimer's to hospital care to organ transplantation. But the reason I took early diagnosis and detection is because it's such a complex problem that takes into consideration many facets of medicine and many facets of machine learning. As a matter of fact, in this Revolutionizing Healthcare session, we have had a double header. One just took place in February the 8th, 2022, and the next one is going to take place in March the 10th. And we have a lot of discussions with leaders in the clinical field around this area, how machine learning can make an impact in enabling clinicians to do better early diagnosis and detection. Take a look if you are interested. And if you are interested in join before March the 10th. So why early detection of disease is so complicated? And here I'm illustrating this with cancer, but the reality is that many diseases can benefit from earlier diagnosis. But if it is to take cancer, you see here two pictorials from BMJ, and I think that they are very nice and very interesting because they show how complex early diagnosis is, how difficult it is for a clinician to look at all the vague symptoms that may be presenting and understand whether there is real disease there or not. And if you look at the current thinking in early diagnosis and detection, I would dare say it's quite outdated. It's often based on risk predictions, where which segments individuals using population-based risks, which are usually based on very few variables. They rarely use longitudinal data, and they are usually calculated only once or very infrequently. The many examples of QRisk, Tyrcusic, or many others are good examples of those. Also, risk scores then lead to guideline-driven management of patients that are often rigid. Plus, in many diseases, we may not even have such guidelines and protocols. So this is all predicated upon a quantitative understanding of disease progression, and that is in many cases quite rudimentary. So why is this hard? Because clinicians have at their availability observations over time, but these observations may be at different moments in time and may be very different. For instance, there may be information about background risk, whether it's family history or other information. Early signs and indicators may develop at a particular moment in time. Non-specific symptoms followed by later in time, maybe too late, specific symptoms. But this different information is what we observe. But what we need to infer on the basis of these observations is something that's hidden, the underlying state of disease of the patient, whether the patient is in a healthy state or has emerging premalignant conditions, or the disease has already progressed and the patient is in a late stage of the disease. All of this needs to be inferred on the basis of the clinical observations made. And the windows for acting and potentially preventing furthering disease, curing disease are limited. So we need to determine that early. And the question is, can machine learning help? So I'm going to present a few ideas today, but if you want to read more about that, as well as the technologies behind some of the things I'm describing here, please take a look at the website that we have. And you can see there an impact section, and there is subsection dedicated to early detection and diagnosis, and you can read much more about it. Let me start with the simplest area, risk prediction. So what can machine learning add on top of the current risk prediction models? First, it can move from a population-based risk to a personalized risk. Number two, it can look not at one risk at a time, but rather at multiple competing risks and look at them jointly. It can also integrate easily very diverse sources of information, family history, social demographic information, but also high-dimensional genetic data that's available about the patient, environmental data, imaging information, etc. And this is important because we often would like to create risk scores that don't look at just one information at a time. but rather complex multimodal sources of information. So for instance, I would like maybe to integrate for a patient that may have high risk of breast cancer, not only family history, genetic information, and the fact that her last mammogram has been normal. I may want to look at the details of that mammogram, whether there are calcifications or other information. So having access to the raw source of information and integrating it jointly with other factors will lead with much more accurate performance improvements. And indeed, our work in a variety of areas has shown that if we are indeed pursuing this approach of personalized risk with different sources of information and integrating diverse multimodal information, the improvements in terms of risk accuracy are much more. Plus, I want to dispel the fact that people believe that machine learning is uninterpretable. This was true a few years back, but there have been significant improvements in making machine learning as interpretable as regressions are. And I'm not going to talk about today, but there are multiple talks of mine online that describe how we can make machine learning interpretable. Also, we can come up with trustworthiness guarantees, which are uncertainty quantification, such that we know when we can trust the machine learning model and when we cannot. So for instance, when issuing a prediction for a particular class of patients, we will know whether we can trust those predictions or not, depending on the uncertainty quantification. Now, another important way in which machine learning can help is not only issuing these risk prediction models, but also learning what information is pertinent. So rather than having 20 different things being put into this risk prediction, maybe we know that for a class of patients, some information is valuable, but for another class of patients, this information is not needed to issue accurate prediction. For instance, patients that may be at high risk of cardiovascular disease, and some of them may be diabetics and some may not. Depending on that, different information may be relevant to issue the right prediction. Machine learning can assess the value of information. So it's not only the more information, the better. It's not about big data. It's rather about the science part of the data science, and hence identifying what sources of information are valuable and for what prediction and for which class of patients. Also, we often have new sources of information, new biomarkers. For instance, liquid biopsies are nowadays a frontier in cancer. And also patients may be changing over time. They may smoke more or less. They may have different types of comorbidities over the years. And this leads to continual adaptation and learning that's necessary. So we need to be able to update continuously when necessary these risk predictions. And this is easily possible using machine learning. And how can we do that? How can we achieve all that? By automating away, not the clinician, but rather the machine learner. So the focus of our research is to automate the data scientists like me and others and create AutoML tools. AutoML is very important because the type of machine learning models that can be used is actually vast, and different machine learning models may be best for different types of data sets and for different questions. I often see papers in the best medical journals, and all they are using is very outdated machine learning models. So, and at times these models will be declared as being fantastic or not. But the reality is whether a model is fantastic or not, we can only know when are selecting the best machine learning model we can have for a particular data set. So how can we do that? By automating the machine learners for automated machine learning. In this way, we can select the best model for the particular data set. So automation is important because we have a vast number of machine learning models, and different models are best for different data sets, but also we need entire pipelines. We need to deal with data imputation, feature processing, classification, and also calibration. So hence, we need to select many different parameters and algorithms at every stage. So it's also, many of these algorithms are not one algorithm. There are a large number of parameters that need to be optimized. And this cannot be done by, usually effectively by data scientists, unless they have a very good knowledge of machine learning. So instead, what we propose is to use automated machine learning to do all of that at the push of a button. And indeed, we have built a tool that we call Adjutorium that can take a data set and a certain type of prediction that's desired by a clinician and create an automated machine learning interpretable and trustworthy risk prediction model. So if you are interested in building risk predictions, this is now done very easily for anything you would like using such an engine. Two examples here again, Adjutorium and autoprognosis, but depending on the complexity of the tool you would like to build, other tools may be relevant. There is a piece on our website dedicated to AutoML where you can learn more about this. I'm going to just highlight a little bit autoprognosis, which is a tool that we have developed for crafting clinical risk scores a few years back. And what it does is it takes a data set and builds such pipelines dedicated to the data set, and it issues predictions and explanations. It can also learn from other complementary cohorts through meta-learning. We have applied this for cardiovascular disease, both in the UK Biobank, as well as other types of clinical data sets. We've applied the same tool to cystic fibrosis, prostate cancer. We have used it together with NHS Digital for COVID-19, breast cancer, etc. So it's a powerful tool that clinicians can already use to build risk scores. Again, if you want to do beyond prediction and you want to do, for instance, time to event analysis, competing risks, or causal models, related AutoML tools have been built by our lab. Again, if you are interested to read more about how to automate the data scientist and how as a clinician, without much knowledge of machine learning, you can build your own analytics, please take a look at this website. Now let's move to something a little bit more interesting, in my opinion, dynamic risk prediction, which is often not done today. Because we have longitudinal observations, we would like to do two things. We would like to integrate the longitudinal information about the patient so far. So that's the longitudinal data to issue forecasts into the future. But also, as we are acquiring more and more data, we would like to update the risk prediction over time. So what we would like to do is to take observations over time and forecast trajectories of health and disease. So we would like to answer on the basis of the longitudinal information we have so far, will event of interest Y, for instance, will this particular cardiovascular disease event, this, for instance, myocardial infarction, appear in 3 years' time? And this needs to be done on the basis of longitudinal information, not only static information, and ideally can integrate, again, complex and multimodal data sets over time. Can be updated regularly when new values become available. So every time the patient may have a new symptom or may visit a clinician, the risk can be updated. And can also include previously unused data sets. So for instance, it could be that suddenly a new data set is linked and now we can issue predictions from more complex information for this particular patient. Similarly, we developed an AutoML tool for longitudinal trajectories and dynamic forecasting that we call clairvoyance. And this was built together with a clinician, Dr. Ari Ercole, who is an intensivist at Cambridge University Hospitals. Let us now go yet one step further. Let's assume that we can make these predictions and forecasts over time. Currently, when patients are seen by clinicians, if they are having a particular suspicion or if they've been developing some symptoms, they are often asked to come back in 3 months, in 6 months, at a pre-specified time, given a quite rigid, unpersonalized protocol. But ideally, we would like to personalize the screening and monitoring. Should the patient come back in 3 months, 2 years, 4 years? So this is also important for screening for high-risk patients, for instance, for breast cancer or other diseases. Often such patients are asked to come back every year if you are in the United States, every 2 years if you are in other countries, every 3 years if you are in yet another countries. The age at which this screening starts, it's in different countries in different times. So ideally, this needs to be done in a data-driven way, and we would like to identify when should a patient come, how it should be screened, and when should they return, depending on the outcome of the current screening. So I would like to identify is the value of information for the event of interest for this particular individual. So machine learning can be very helpful here by enabling us to identify who to screen, when to screen, and what to screen. And here are some of the examples of the technologies that we have built. For instance, here is an example from breast cancer where we have learned on the basis of observational longitudinal data, dynamic personalized screening and monitoring schedules. And what you see here is, for instance, two patients, patient 1 and patient 2, they have the same features but different histories, and hence they would lead to different screening, as opposed to patient 2 and patient 3 that have the same history, but they have very different, for instance, genetic information, and this may lead to different screening. Another thing that we have built, and this is together with some radiologists at University of California, Los Angeles, quite a few years back now, is what modality to use when screening for women for breast abnormalities. Shall we ask the woman to come back and when, but also what type of modality should be used? Should they be given another mammogram? Should they be given a mammogram and an ultrasound? Or should they be given an MRI? What is the value associated with acquiring this particular modality for this particular patient, given their unique characteristics? Let us now talk about how to detect disease early. As I mentioned before, early diagnosis is more than just event prediction. It involves understanding how disease progresses, how long a patient may be in a particular state before it progresses to a next state. For instance, the emerging premalignant condition may be a particular state that may be in a particular class of patients taking a few years, while in some others may progress much faster. So understanding states and stages of disease, as well as understanding the duration in them, it's very important. And again, I'm not talking here only about stages of disease such as cancer. I'm talking about a very general concept that can be applied to any disease, that concept of state. And stages of cancer could be associated with particular states. This will provide us a quantitative way to model disease progression. If you look at state-of-the-art models for disease progressions in medical journals, and I'm talking now really about state-of-the-art, you often will see what I call a Markov model. You will see disease progressing through a number of stages. Often the number of stages are predetermined. And what's a problem with this type of model is there are actually many, many problems. First, the assumption is that I can observe the stage of disease of a patient, but many stages of disease cannot be observed for many diseases. Also, these models are Markovian. So what does that mean? The entire history of the patient doesn't matter. Only the current stage matters. Another disadvantage is that they model one disease at a time. So I could have multiple diseases that they interact, but this is not captured in this type of models. Also, this is one size fits all. The probabilities of transiting among stages are average across all patients. One particular solution that can be used to alleviate some of these issues is to move between Markov models to what we call hidden Markov models, where we no longer make the assumption that we observe the stages of disease, but rather infer on the basis of the observations the underlying hidden stages of disease. So I have, for instance, here highlighted on the right, observations, family history, symptoms, lab tests. They are the observations, we can see that, but on the basis of this, through machine learning, we can infer the underlying hidden state or stage of disease of the patient. We can learn in this way the underlying characteristic of the disease of the patient at the current moment in time. This is still not enough though, because it ignores the history of the patient. It's still Markovian. The order of the states is ignored and the duration of a state. is important. Often patients may stay a certain number of months or years in a particular state, while others may transit much faster. None of that is possible in the hidden Markov models that I described before. Also, they are still one size fits all. So the genetic information, for instance, of the patients is ignored. Can deep learning models come to the rescue? Well, the answer is no. A lot of the machine learning models that exist, for instance, for natural language processing and a variety of other areas in machine learning cannot apply to medicine. And the reason they are not applicable to medicine is that they are often uninterpretable, both in terms of predictions they make, as well as the latent structure that they learn. So a few years back, prompted by discussions with clinicians, we developed a model that combines the power of hidden Markov models, which are these state-based models, with the power of machine learning to model complex non-stationary representations at the patient level. So what we did is we combined the hidden Markov model's ability to model these hidden states, which enables us to understand disease progression, with the power of machine learning to model complex dynamics over time and deal with nonlinearities and enable us to easily incorporate individualized patient features. So what we created is this attentive state-space model highlighted here. And what you can see, there are two important advances. One is we are no longer Markovian. As you can see, the transition between one state and another may depend on the entire history of past states. And also, unlike in the past, when we were one size fits all for the entire population, now we can feed in the patient context, and that can modulate these attention weights. So the unique characteristics of the patient, for instance, genetic information, can be incorporated and modulate the transition probabilities among states of disease. So the relevant history is now shaped by the patient's current context, and this can include also treatments. And this is an advance as opposed to past models. And we have applied this to a variety of diseases, inclusively cancer and cystic fibrosis. Now, how can we use these trajectories of disease to do early diagnosis? We learn on the basis of the available data at training time these trajectories of disease for patients. Then, at test time, when we have a patient in front of the clinician, we may have observations about their genetic information and some non-specific symptoms. Then, if we do not have machine learning at our disposal, we may say, well, the patient doesn't have any particular disease, and we may tell the patient to come back after a long time, by the time which a diagnosis is made, but too late because the disease has progressed to a too advanced level. Instead, what we can do is, because we have now machine learning, when we are in this particular state of disease, or when we observe these non-specific symptoms, we can infer that we are at an emerging premalignant condition, and we can tell the patient to come back much faster because we suspect now that the pathology is present much faster, and hence we can do early diagnosis. What about treating disease? Not for the sake of diagnosis, not for the sake of treating a diagnosed disease, but rather to limit or reduce the risk of a patient that may be at high risk for the particular disease. Treatments with the overall goal of potentially limiting the chance of the patient to develop a more complex or a more advanced stage of disease. Well, this is a more complex problem because this is not a prediction problem. This is what we call a causal inference problem. We need to answer what-if questions, counterfactual questions. We observe the patient history and the unique characteristics of the patient, and we need now to answer questions such as, what will happen to the patient if I give a treatment or I don't give a treatment? So what we would like to understand is the effects of the treatment at a particular moment in time on a particular individual. We would like to understand how to treat, when to give treatment, and when to stop treatment. And this is complex because what we have at our disposal is not a randomized controlled trial, but rather observational data that is biased. So we have time-dependent patient features, time-dependent treatments, and static variables, which form the patient history. On the basis of this, we need to determine what will be the effect of treating in a particular way, the particular moment in time, the patient or not. So we need to identify the outcomes associated with these different potential paths of treatment. So we need to deal in this way with a causal inference problem, and we need to deal with the bias available in the data. And what's trickier is because we have longitudinal data, we need to deal with time-dependent confounders. And these are patient covariates that are affected by past treatments, which then influence future treatments and outcomes. How can we deal with that? There are multiple ways to deal with it, but in recent times, we developed a technology that is able to take the past observations of the data and then build sequences of future potential counterfactuals. And this resembles, but goes one step forward, than translation methods. So you can think about what happened to the patient so far is one particular language, English, but then depending on the treatment you give, you move to another language. So similarly to sequence translation models, this model is built, but has more complex, has need for more complex innovation because we need to deal with the biases available to given the treatments. So we need to deal with these debiasing effects. And we do that using domain adversarial training. Now, how can we put the different pieces of the puzzle together? How can we really put the right team of clinicians in charge to diagnose a complex patient with very complex symptoms? For that, machine learning can again be helpful. And what I have in mind here and what we have developed is not a recommender system like the one you are using when watching Netflix, which learns over time what movie to recommend to you based on your past liking or disliking of this particular movie. Similar to that, but in a more complex environment, we learn what teams of clinicians need to come together given the unique characteristics of the patient and the current symptoms they have. So we learn how to build teams of experts to enable fast and accurate medical diagnosis. So we built recommender systems that recommend not movies, but rather teams of clinicians. So another final thing I'd like to talk about is variation in practice. As a patient, often I would like to be diagnosed by the best possible clinician. But the reality is that if I would have a particular disease and I go to multiple doctors, often different diagnoses are given by the different doctors or at different moments in time. So we would like to keep the variation in practice that's due to the individual characteristics of the patient, but we would like to eliminate the variation in practice that's due to the inconsistencies and potential biases of clinicians. How to deal with that? We have developed, again, together with several clinicians in Cambridge, a new type of machine learning that we call quantitative epistemology. And the goal of that is to understand variation in practice. For instance, we have looked at Alzheimer's diagnosis, which at times is done late, and at other times it involving an unnecessary number of MRIs or imaging tests. So we look at the different variations among the clinicians and what may trigger this variation for what classes of patients and in what scenarios, under what type of uncertainty. And we do this with the overall goal of empowering clinicians such that they realize this type of variation and they can act upon. And the type of questions that we are answering with quantitative epistemology are: how timely is a particular decision? What type of subjective beliefs may the clinician hold? How does that relate to an optimal policy that can be applied for that particular clinician? How do beliefs change over time as clinicians are becoming more familiar with a particular disease? and they are advancing in their profession? Can we build more interpretable ways of human behavior and decision-making in the diagnosis setting to enable, again, clinicians to act more promptly? And how does learning of clinicians evolve over time? So hopefully this gives you an idea of what is possible. And we really hope that early diagnosis and detection involves a large number of clinicians with different types of specialties. Hopefully, over time, by making partnerships with clinicians, we can develop tools for all these different clinicians, whether it's primary care clinicians, whether it's clinical researchers, geneticists, or radiologists. Again, if you are interested in this, please come and join us on March the 10th when we talk again about early. You can look at own research, or we can and has as co-director Professor Andre has multiple other clinicians from university hospitals. So take a look and please engage with us. Thank you very much.
Thank you very much, Professor. That's interesting. And we have a few minutes now, so if it's okay with you, we could see if any of the questions, students have any questions.
Sure.
Hiya, sorry. I have a question, if that's okay, and then I'll ask it and then I'll stop the recording.
Sure, sure.
In the vein of having kind of high impact in the world, and so it was really encouraging. Almost every paper that you cited, you said, in collaboration with this clinician or in collaboration with that clinician, and so on. So I just wanted to kind of find out a little bit more about the relationship that you have with clinicians as an AI researcher. So what kind of roles what kind of input do you put into the team? What kind of input do they put into the team? And how do you kind of work together between yourself and the clinicians?
Thank you. That's such a good question. Thank you, Rahul, for that question. So we collaborate with clinicians at different levels in many different ways. In these revolutionizing healthcare sessions, we are collaborating loosely, meaning that we discuss with each other about problems of interest, try to understand them, and try to define them as clearly as we can, and divide the problem that the clinician is trying to solve or would need assistance with in small building blocks that maybe we can build and we can design. Let me give you one example. For instance, we were trying to build methods in COVID to try to help clinicians, in this particular case, clinicians at the University of Amsterdam, who were treating patients with dexamethasone, and they wanted to know whether different dosage would be needed for different types of patients depending on their characteristics or stage of disease. So that's a problem that they brought to us, and in collaboration with them, we have developed some methods to enable such personalized dosage. This is just one of the examples. But in other cases, it was even more basic and fundamental from a machine learning point of view. So we have a collaborator in Cambridge who is a consultant hepatologist, Professor Dr. Alex Gimson, and he has collaborated with us to build systems for better transplantation, for better matching patients that are on the transplantation list with organs that are coming. And that is a problem that is so interesting and so complex. So we ended up collaborating in over quite an extended period of time, and we are continuing to collaborate because we built some tools, then we realized that we can do even better, that we forgot this complexity of transplantation or that complexity, or that this is good for this type of organs, but if you talk about other types of organs, it's not. So to some extent, this is an ongoing conversation where we keep on building tools as we are conversing with clinicians. So this is a very, if you like, intensive collaboration with some. With some others, we mainly discuss about tools and opportunities, and we point them to the right opportunities in the hope that they, with their own data scientists at their own location, can join forces and do something together. Because we are an academic group, so unfortunately we cannot do too much.
No, yeah, thank you so much. Correct me if I'm wrong, but it feels like, you know, educating clinicians about what can be done so they don't miss opportunities to come to people like yourself and your group is also quite key.
So this is what I would like to do, Rahul and Mihaela, and hopefully you can help me. Maybe you can join forces with me to do that. So I really feel that we would need almost like a summer school, you know. We have often summer schools for machine learners to learn about a variety of things. It seems to me we almost need like a summer school for young clinicians to learn about AI that is jointly run with a summer school for machine learners who need to learn about medicine. That seems to me like a very good opportunity to put the two young communities together, because I think that this would be transformational. And maybe we can do that in Cambridge sometime soon. So if many of you are interested in that, please reach out. Maybe we should just be doing that.
Yeah, I think it's very interesting that you say that, Professor, because I've actually found that when reading about machine learning, it's a kind of a big barrier for well, for students and I suppose for clinicians, is that when reading, for example, about different types of modeling that they're using in like these medical research papers, without understanding the fundamentals of machine learning and kind of the basics, like how it works, it's difficult to understand the papers and to know what kind of questions to ask. But I think you're right that some kind of course teach medical students.
So Mihaela, thank you for that. I want to revert that question a little bit to you. So I know that what you are saying is true, but I think that it is not needed for the clinicians to know the nitty-gritty, boring machine learning part. So what we are going to try to do, and I'm going to try to do this with the clinical collaborator in Cambridge, who is clinician, so Dr. Eoin McKinney. We are going to try to see if some of these revolutionizing healthcare sessions, we can turn them a little into some semi-educational sessions where we describe what is possible with some good examples and not how it's done. Because the reality is, let's assume that you are an architect. My mother was an architect. She used to use a lot of programs without understanding what's inside those programs, the nitty-gritty CAD details or computer-aided design, or you don't need to know something. They're almost like Lego blocks. As a kid, I used to love to play Lego. By now, I guess nobody plays with Lego, but you can think almost like these Lego pieces that learners build for you. And then you, the clinicians, can put these Lego blocks the way you like to build some system for you without the need to understand all the nitty-gritty that's in the boxes. As long as these boxes are well specified and well designed and they are trustworthy and clear, maybe you don't need to know all the nitty-gritty. And I think that's I think the model that we are trying to evolve to. So I hope you'll join us in these sessions. We are going to start that in May. So we are going to change a little bit the format, because indeed, I think the biggest opportunity is to try to bring these two communities together and try to do that at the level, at the conceptual level at which we can interact without me needing to understand medicine and you needing to understand the nitty-gritty of machine learning.